When you walk through the halls of the Mütter Museum in Philadelphia, Pennsylvania, you see a wide range of medical anomalies that tell stories about the human body. There are preserved organs showing rare diseases, skulls shaped by unusual growth patterns, and skeletons altered by injury or illness, with wax models used to teach anatomy long before modern imaging existed. Each specimen is there to help us understand what can happen when biology takes an unexpected path. But among them, there is one skeleton that stops most people in their tracks. At first glance, it looks as though the body began building its own suit of armor. Sheets and bridges of bone wrapped around the spine, shoulders, ribs, and hips. Joints that should move freely appear locked in place. Bone connects to bone in ways that don't match normal anatomy, as if the skeleton slowly grew outward and inward at the same time. That skeleton belonged to a man named Harry Eastlack. Harry Eastlack had a disease called Fibrodysplasia Ossificans Progressiva. How doctors came to understand FOP. Long before Fibrodysplasia Ossificans Progressiva, or FOP, had a name, it was already being observed. Some of the earliest descriptions date back more than 3 centuries. In the late 1600s and 1700s, European physicians recorded unusual cases of people whose bodies seemed to gradually harden. These early reports describe patients who became, quote, petrified, because there was no medical understanding of what caused these symptoms. A notable early case came in 1740 when John Freak presented to a royal society a young man with widespread hard masses that restricted his movement. The condition had not been present at birth but developed over time, which is still characteristic of FOP today. As the centuries progressed, more reports emerged across Europe. Physicians eventually noticed a pattern that people with these unusual bone growths also had malformed great toes present from birth. This helped distinguish FOP from other conditions like myositis ossificans traumatica or metabolic bone disease. In 1970, the geneticist Victor Mikusic formally named the disorder Fibrodysplasia Ossificans Progressiva. The term highlighted the abnormal fibrous tissue development, bone formation, and the relentless progression of the disease. His classification placed FOP within the broader family of hereditary connective tissue and skeletal disorders. One of the most influential modern cases was Harry Eastlack, a man with classic FOP who donated his skeleton to the Mütter Museum in Philadelphia before his death in 1973. His remains have become one of the most studied FOP specimens in the world, providing valuable anatomical insight into how the disease progresses. Carol Orzel, another individual with FOP, later donated her skeleton as well, contributing to both medical education and public awareness. Today, large natural history studies and molecular research have confirmed what early clinicians could only guess, that this seemingly mysterious disease has a consistent pattern, a recognizable appearance, and a clear genetic cause. Understanding FOP. When bone grows in the wrong places. Fibrodysplasia ossificans progressiva is an extremely rare genetic condition in which muscles, tendons, and other connective tissue are gradually replaced by bone. This abnormal process, known as heterotopic ossification, meaning bone forms where it doesn't belong. Over time, people with FOP develop a second skeleton made of extra bones. This bone growth is irreversible and severely limits movement. Most individuals with FOP become dependent on assistive devices by early adulthood, and life expectancy is often shortened by complications involving the lungs, heart, and mobility. The root cause of FOP is a change in a single gene called ACVR1. This gene normally helps control when and where the bone should form by producing a receptor that acts like a biological switch for listening to growth signals. In people with FOP, that switch is stuck in the on position. The receptor becomes overly sensitive and responds to signals that should not trigger bone formation. As a result, cells and muscles and connective tissue begin building bone in places where bone doesn't belong. In almost all classic cases, the underlying problem traces back to the same spot in the gene, a single letter substitution known as R2O6H. This small chain causes the receptor to overreact, even to normal biological messages that should be ignored, activating a pathway called BMP signaling and launching bone growth inappropriately. when the body builds a second skeleton. In FOP, the body forms new bone inside soft tissues like muscle, tendons, or ligaments. This happens through a process called endochondral ossification, the same sequence the body uses to build the skeleton during early development. It usually starts with inflammation. A part of the body becomes swollen, sore, and warm to the touch. But instead of healing normally, the body sends signals that go too far. The injured tissue gets replaced, not just repaired. First, the muscle or connective tissue is replaced by fibrous tissue, which acts like scaffolding. Then that fibrous tissue turns into cartilage. Over time, the cartilage hardens into real bone. And it's not just calcium buildup, it's fully structured bone with marrow inside, just like the kind found in skeleton. The difference is the bone grows in places it shouldn't be, and once it forms, it doesn't go away. It can restrict movement, fuse joints, and make once mobile areas of the body permanently stiff. As FOP continues, it tends to follow a recognizable path through the body. In most people, the first areas affected are the upper half, the neck, shoulders, and upper back or spine. Over time, the extra bone begins to form further down, involving the arms, hips, and eventually the legs. The pattern isn't always exact. Some areas may stay flexible for years while others become stiff much earlier. But overall, the direction of progression is usually from top to bottom. The most active period of new bone growth usually happens between late childhood and early adulthood. During this time, roughly between the ages of 8 and 25, flare-ups are more common and more likely to leave behind permanent bone. After age 25, the progress often slows, but it doesn't stop. FOP can continue to progress little by little throughout adulthood. There's no known way to safely remove the extra bone, and in fact, surgery or even minor procedures often make things worse by triggering new flare-ups. Because of this, surgical intervention is generally avoided unless absolutely necessary. Even though FOP causes major changes to the skeleton and connective tissues, many parts of the body actually remain unaffected. The brain is not involved, so thinking, memory, emotions, personality, and awareness all stay normal. People with FOP stay mentally sharp and fully themselves throughout the course of the condition. The internal organs, like the heart, liver, and digestive system, also remain structurally normal. These organs can be affected indirectly if, let's say, nearby bone limits the space or puts pressure on them, but FOP does not damage the organs themselves. Recognizing FOP, early signs, diagnosis, and flare-ups. FOP is often first suspected during early childhood when unusual symptoms begin to appear. One of the earliest and most consistent physical signs is found in the big toes. In nearly all individuals with classic FOP, the great toes are abnormally shaped at birth. They may be shorter than usual, angled inward, or made of only one bone segment. This specific toe difference is not seen in other conditions that cause extra bone growth and has become a key diagnostic clue. When painful swellings or flare-ups begin in childhood, especially in combination with these toe abnormalities, doctors may consider FOP and pursue genetic testing. In most cases, the diagnosis is confirmed by identifying a mutation in the ACVR1 gene, which, as we mentioned, controls part of the body's bone growth signaling pathway. Flare-ups are the hallmark symptoms of FOP. These are episodes where new bone starts to form inside soft tissues. They often appear without warning, but certain triggers are well known. Even minor trauma, like bump or a fall, can start the process. Intramuscular injections, tight clothing, dental procedures that involve opening the jaw, or viral illnesses such as influenza can also act as triggers. A typical flare-up begins with pain, swelling, and warmth in the muscle or connective tissues. The area may become red and tender, and sometimes a firm lump appears. These flare-ups can grow quickly and may look or feel like a deep bruise or soft tissue mass. Nearby joints often become stiff or difficult to move. This stage is driven by inflammation and can last for days or weeks. As the swelling settles down, the affected tissue starts to harden. Over time, that soft tissue is gradually replaced by bone, and the new bone may connect or fuse nearby structures that were once separate, leading to permanent restriction in movement. Recognizing these early signs, both visible toe differences and the way flare-ups behave, is critical to diagnosing FOP before harmful procedures are performed. Early identification can help avoid biopsies or surgeries, which often worsen the condition. This has been the Brit Factor with Bonafide. Thank you for learning with me.